Right, good morning, everyone. Thank you very much for joining this guest lecture. Actually, not really guest lecture also because Prof. Dr. Voon Pei Jye, is currently one of our adjunct professors as well. But he is a consultant oncologist in Sarawak General Hospital. In fact, the only center in the whole of Sarawak covering. And today we're very glad that he is here with us physically in our faculty, FPSK, to give a talk on immunotherapy in cancer. I think since my medical student days, oncology has progressed so much that a lot of therapy that even myself not very clear. So I'm very glad that Prof. Voon is here to give us a talk on this very important topic. Welcome, Prof. Voon. Let me put up the slide for you.
Yeah, thank you so much. Chill.
All right, can you hear Prof. Voon?
Can you hear me?
If you can just type yes in the chat box.
Oh yeah.
Okay.
Okay, thank you. So, thank you so much, Prof. Chiu, on actually a very kind introduction. And of course, I'll be very, very happy to be here today because I'm actually an alumni as well for university many, many years ago.
I'm the very important point.
I'm the second actually batch of medical students.
Second batch.
Yeah, second batch.
Yeah.
Together with some of my friends still here, one like Professor
Tang,
Tang, and the team actually. I'm the classmate of Dr. Tang. So it's always great to actually come back to our university and where we start to, our career. And thank you so much for joining me today as well. So today I'm actually would like to share with all of you something that is very exciting. It's not very new, has been there for more than decades. It's actually immunotherapy and cancer, but things is still evolving very, very fast. And things keep on changing. Almost as we speak, I think things are still changing. New data is coming up and how to actually sharpen as well as refine the way that we treat cancer with immunotherapy. So this is my disclosure. And after that, I think the most importantly, how to actually, I would say analogically, say what is immuno-oncology. And I think it's something that it's just like driving a car, in simple terms. It's simple. And one thing is that, in a car, you need to actually, start the car engines. And that is part of the very important component in immuno-oncology. And at the same time as well, you actually have accelerator that move the car. And there's a brake that actually try to stop the car, otherwise your car will go in uncontrolled. And of course, even more importantly here is actually the highway. That is a tumor microenvironment. So this is a concept that, we can see conceptualize it as immuno-oncology. It's just like driving a car. I will actually explain more and probably in the future, in the last few slides, and you'll get to understand why I use actually the analogy of car in immuno-oncology. So there are many types of cancer immunotherapy. Like for example, vaccines, cancer vaccines, you can see from here. And we can actually use small molecules as well, which can be agonists or inhibitors. And of course, the cytokines is very important. And cell therapy as well, the CAR T cell, which is actually very well established in hematology malignancy. In solid tumor is still ongoing, the research itself. And of course, I want to highlight is immune checkpoint inhibitors. That is the current molecule like CTLA4, PD-1, and PD-L1. Why I have highlighted this is just because drugs has been approved, for this group of immunotherapy, which actually has been transforming the care of cancer since the past 1 decade. So what exactly, molecularly immuno-oncology, is very, very complex, but in simple term is, you can see from this chart itself, the MSC represent the cancer antigens. Cancer antigen is not a normal antigens. We call it neoantigens actually in cancer. That be presented by MSC by the APC, the antigen presenting cells or the tumors, and it present over to the T cells. So that T cell will react against these cancer antigens. and then of course mild immunity against the tumor cells. And overall, what you can see on your left, on your right, sorry, yeah, on the T cell itself, they are actually broadly divided into two signals. One is an activation signal that actually activates the T cells, and these are actually modulated by the interaction between the receptors. Here we can see multiple receptors that has been discovered and being studied, and drugs being actually developed against it as well. Like for example, OX40 is one of the very famous, T cell activation receptor and on T cell itself. And of course, it's in the body itself, homeostasis is extremely important. When there is activation, definitely there is inhibition as well, so that there is no overactivities of the immune system and also no underactivity of the immune system as well. This is in the ideal situations. So you can see from here, there is actually a signal of inhibition also. So we call it checkpoint inhibition. It's just like a brake as well. You can see on the left, the picture itself, a brake on the immune system, just making sure that there is no overactivity of the immune system, which can induce actually problem, like for example, autoimmune disease, all those things. All these are actually, you can see the concept of autoimmune disease in the body. Then the inhibition signal modulated by different molecules as well. So I think one of the very few important one is actually how come it's sorry. Oh, this one. Okay, sorry. Not working. Sorry. So I probably need some help on moving the slides. But anyway, the current important, I would say currently those immunotherapy that has been approved is mainly focusing on the immune checkpoint inhibition. There are three, molecules that has been utilized in immune checkpoint, and one of them is actually CTLA4, PD-1, and LAG-3. These three, these three I've highlighted here. Yeah. So these three, sorry for the hiccups. I wonder whether, are you able to see the slides?
Okay, can you see the slides? Okay.
And able to hear me?
It's type in the chat box. Can you see the slides?
I think it's yes. If let's know, please let us know. Yeah, so sorry for the technical. Yeah, okay, they can see and they can hear as well, I think. Yeah. So this checkpoint inhibitor itself, is the one that the molecules that has been developed and drugs against it, has been established and approved as well. So at this moment, the focus is actually PD-1, which is actually very, very established. There's a lot of anti-PD-1 have been used so that we can actually dampen the immunity of, inhibits the dampening of the immunity against the cancer cells. So what cancer cell do actually is cancer cell is very smart. They trying very hard to outsmart our immune system by manipulating either the agonist part of the T cells or the antagonist part of T cells, meaning the inhibitory part of T cell, the immune checkpoint molecules. So what we do at this current point in time is try to, I would say, counteract against those inhibitions signal by producing drugs like, for example, monoclonal antibodies against this receptor, which is being manipulated or utilized by the cancer cell to dampen the immunity against them. I think this is a basic concept of this is a basic concept of, at this current point, what is happening in immunotherapy in cancer. So if let's say we look at this is the antigenic stimulation. We look at it more closely. So initially, this is a naive T cells, and you have actually antigens, neoantigens from cancer, and this will be captured by the antigen-presenting cells in the immune system. And this antigen-presenting cell, you present this initially at the lymphoid structures, meaning in the lymph nodes, but via the priming effects. So it's the first activations against these new antigens in the, from cancer in the body. So in this, it will try to activate the T cells actually in the lymph nodes. And all these activated T cells will proliferate, and after that, will differentiate it as well, and they'll move to the tumor sites. And in tumor site itself, and the tumor cells will present again to these T cells, and all the, supposedly all the, I would say, the lysis and the action against effectors, mechanism against this tumor cell should happen. But unfortunately, this what we want, the ideal situation is not happening. That's why cancer can continue to grow and continue to proliferate. It's because, the cancer cell itself actually are manipulating our, immune inhibitory mechanism, which is, one of it is the CTLA receptor in the lymphoid structures, as well as PD-1 receptor in the tumor sites. And for this, when they manipulate as well as utilizing this receptor by the cancer cells, and it would actually, dampen the immunity action against the tumors. That's why the discovery of all these have actually led to the discovery of the drugs against this immune checkpoint receptor. And hopefully with that, we can actually, reduce the dampening of the immunity, and hopefully we can actually enhance the immunity against back the cancer cells. So the role of immune checkpoint inhibitors, so at this current moment, the only approved drugs at this time actually mainly is actually the immune checkpoint part, and it can actually be, one of it is anti-CTLA-4, which actually is acting at the, the lymphoid structures area, and in against this immune checkpoint of CTLA-4. And so one of it is, ipilimumab, which has been, I would say, approved more than 10 years ago. And the other groups is anti-PD-1 at the level of tumor cells. And there are multiple drugs from different company, and it's including anti-PD-1 or anti-PD-L1. And this is including nivolumab, pembrolizumab, cemiplimab. And for anti-PD-1 is avelumab, durvalumab, as well as atezolizumab. All these are monoclonal antibodies. So all these are important, I would say, weapons for us against the cancer cells in terms of immune oncology. And I think one thing is very interesting is, and even though we think that this probably will work for everybody, but it's not the case. And a lot of them may not be actually, I would say, working well in certain tumor types. And of course, there is more to it. So what about other immune checkpoint inhibitors? So for the about, I think 2 to 3 years ago, there's another receptor that has been utilized, and drugs has been developed against it. And eventually a drugs has been actually, approved as well. And this is actually the LAG-3. It's one of the immune checkpoint as well, at the inhibitory signal part. So this drug, the name is Lulalimab, which is actually in combination with nivolumab, the anti-PD-1, anti-LAG-3 plus anti-PD-1. And this is again been very successful in the drug development sphere in melanoma, and eventually actually FDA approved it for unresectable and metastatic melanoma. And these are all the approved, immune checkpoint inhibitors for across different tumor types. And you can see from here is a busy slides. Almost all the cancer in almost all the organs actually have drugs approved for immuno-oncology, and specifically immune checkpoint inhibitors can be used for most of the cancer in our body. And you can see from here, specifically looking into lung cancer, which is a very, very common cancer and very dear to my heart as well for this, because I have a special interest in lung cancer. So you can see from here in 2015 to 2023, there are so many actually drugs being approved in whether it's a monotherapy or actually in combinations, whether in first line or in second line in metastatic non-small cell lung cancer. And one thing very importantly here as well is continue to evolve. And you can see from here beyond the PD-1 and PD-L1 inhibitors, meaning beyond actually immune checkpoint inhibition. So there is, you can see from a number of IO clinical trials according to type of IO drugs. multiple clinical trials in different, category of, immune system. Like for example, or whether in monotherapy or in combination. Like for example, cancer vaccine in combination, anti-PD-L1, or other types like even cell therapy and other immune agonists in combination of immune checkpoints and all those. So you can see a lot of things happening. Actually, it's one of the most robust in drug development in oncology. And as well as the target of IO drugs in clinical trial as well. You can see it's very, very colorful. It just means that every color is different targets that people are looking at it. And the size of the bubble itself is actually depending, it's actually in accordance to, uh, numbers of trials that actually are looking into these specific targets. Is you can see from these two, picture itself, there a lot of robust development, and I'm quite sure that actually oncology is one of the most robust across all the therapeutics area or discipline that is currently happening and in across all area of medicine. And next question is, we know that not everybody is going to benefit from the immuno-oncology or immunotherapy, specifically immune checkpoint inhibitors. The next question come out will be, can we predict whether which patient or which tumor type is going to have response or going to have activities from these tumor types, from this immunotherapy? So it's a very difficult area because at this current point in time, there's no perfect markers. Meaning, if let's say you have this marker, then definitely the drugs are going to work. It's not the case at this current point in time. So the reason is there's multiple biomarkers because you can see already there's multiple targets that can be utilized. And another very important thing is that all these markers at this current point in time is a continuous variable. Like for example, PD-L1 expression is from 1% to 100%. So it's not something a sum zero game. It's not like if let's say you have that markers, definitely the drug is going to work. That's why it's a continuous variables, and meaning that it's not something that very, you can categorize it like very certainly like some zero game kind of situations. And at the same time also, the tumor intrinsic extrinsic factors is very, very complex. You can see from here, even for immuno-oncology, there are cost factors that can influence the effectiveness of the drugs, like the microbiomes, the germline genetics, and also the tumor itself, the intrinsic factors, the tumor mutation burden itself, because every cancer, actually, every tumor types, even the same tumor types in different individuals are very unique. And the tumor mutation burden varies even within that tumor type itself. And the new antigens, the antigen presentation part as well is very important. And another very important area that is has been very actively been looked into is the tumor microenvironment. In tumor itself, there is an environment, and we call it a microenvironment itself. That a lot of things happening there. Not only tumor cells, there are many types of cells inside there, even the tumor infiltrating lymphocytes, the tumor and myelosuppressive cells, like regulatory cells and all those. It's not all the lymphocytes or the white cells are good cells. Some of them are actually so-called not the good cells as well, that actually is dampening the activities of actually the immunity. And of course, the clinical factors as well. Whether if let's say there's a continuous exposure to carcinogens, despite you keep on throwing drugs against them, but this less exposure is continuous, then the drug may not be effective. And of course, like for example, sometimes some patients are on corticosteroids, which we know that is immunosuppressive for certain reason. And so if let's say you're throwing an immunosuppressive into this immuno-oncology or immunotherapy, then there's a chance that actually the immunity may not be working so well. The drugs may not be working so well because the drug actually basically is trying to enhance our immune system and to fight against the cancer. And at this point in time as well, as a predictive biomarkers, neither of them are very sensitive or very specific. And even more, troublesome is actually the mechanism of resistance. Eventually, in stage 4 disease, a lot of these patients, even though there is an initial response to the drugs, for the patient, but subsequently, a lot of them will continue to progress. Like, for example, they may respond for 1 or 2 years, but subsequently, the cancer may continue to grow after that. Because cancer can actually acquire resistance. They can actually, have I would say, initiate some pathway that then serve escape from the activity of the cancer cells. And all our predictive biomarker at this current moment are not able to translate into what exactly is the resistant mechanism of the drugs. So that's why I mean, essentially is there is no, at this current moment, a predictive, I mean, perfect predictive biomarkers that we have against cancer cell via immunotherapy. So what we know at this current moment, which is very established in terms of predictive biomarkers, we have some, but not perfect. One of them is actually the PD-L1 status, because you know that one of the drugs against the PD-L1. So the PD-L1 expressions can be used to predict whether the drug is going to work well or not. So this is one of the trials that looking into it is Keynote-042. It's a non-small cell lung cancer trials. And you can see from here in terms of overall survival, OS, the survival curve, if let's say those patients with higher TPS score, meaning the higher PD-L1 expressions, at least more than 50%, then immunotherapy is better than chemotherapy in terms of the overall survival curve. Yeah, you can see the pembro versus the, I mean, chemotherapy in the survival curve itself from these trials, Keynote-042. And if let's say, I mean, 1 to 49%, the survival curve itself, the separation is not as good as those, at least more than 50%. But however, we can see from here as well, eventually all this survivorship will continue to reduce over time, meaning the patient may develop resistance against these drugs. And another area that, I mean, quite fairly well established as well, and actually approved indication for, I mean, like, for example, the anti-PD-L1, one of the drugs, say, pembrolizumab, actually has approved for high TMB, tumor mutation burden. And you can actually analyze the NGS and then get the tumor mutation burden. And we know that if, let's say, the tumor mutation burden is high, the chances of immunotherapy to work actually is better. Tumor mutation burden, usually we can say in simple terms, is the dirtier the genetic makeup of that cancer, and usually there will be more new antigen being developed, and then so a lot of time all this thing is like, you know, the genetically there are more aberrants, and the chances for the immunotherapy to work actually is higher. And of course, you can see that PD-L1 is high, TMB is high, usually indicates that the immunotherapy is going to work well. But unfortunately, I mean, there's a curveball being thrown into here. It's the anti-PD-L1 association with TMB. There is actually no direct association, no linear association. That actually poses a major challenge. Even though PD-L1 can be high and TMB can be low for that tumor types. So this actually poses a major thing is that it's not perfect markers. Some of them has only PD-L1 high and TMB actually is low. But would that mean that the drugs can be used? I mean, well, I think it's still a major question, but of course the drug is actually approved based on PD-L1 or based on actually TMB, but it's not approved based on the combination of both. So that also gives us an idea that actually this is not perfect markers, because you don't see the linear, I mean, correlation between PD-L1 and TMB. And one more thing is that, I mean, sorry, I mean, how can I go back? It's not moving again. Oh, sorry. Uh, this slide, 14. Okay. Then, I mean, it's even made even more complex is actually the interaction between the immune system and the cancer cells, and especially at the mechanism of resistance. Now we know that the drugs doesn't work for everybody. So what are the mechanism of resistance? So the mechanism resistance is something that is very complex and it's very dynamic as well and rapidly actually evolving. So one of it is actually the intrinsic mechanism, meaning the tumor cell itself, before even you throw in the drugs against them, they already have mechanism of resistance against this immunotherapy, as shown in these pictures. And of course, there are external mechanism of resistance as well. These include, I mean, just now I have mentioned a few, like the activity of the T regulatory cells, the myelosuppressive cells as well. And at the same time, all the, I would say, you know, the pathway that being utilized by the tumor, like for example, IDO pathway and all those, actually those also can actually contribute to the external mechanism resistance to the drugs. That's why you can see that there's so many mechanisms of resistance. Definitely, the predictive biomarker is very difficult to get because you're only looking at one expression of the thing that potentially predicts. But there are so many things that is happening inside the tumor that actually cause the drugs may not be working well. So the predictive biomarkers is something that, I mean, everybody's looking at, and hopefully we can actually develop it. And with that, I mean, people are looking into more integrative study or looking at how to improve the predictive biomarkers. The way to go, actually, I think, I believe in as well, is the integration of data. Hopefully with the AI and all those, then we can actually make this even more robust and we can get even better results. So for example, people are looking into integration of actually clinical, genomics, as well as transcriptomic biomarkers. And you can see from here, there is a very interesting study looking at this, the SU2C MARC study, actually looking at the non-small cell lung cancer cohort. And you can see this heat map as well, and the color of the heat map itself. Then you can see that they're actually able to identify all this integrative information into different cluster. The first cluster is a cluster 1, which is actually a resistant cluster, which actually saw that the patient actually had EMT, TGF-beta, as well as myeloid signatures. And of course, there are cluster 2, which actually is sensitive to the immunotherapy. And these are the factors, the PD-L1, for example, if let's say we have anti-PD-L1 and the patient tumor have PD-L1, then of course there is a higher chance for it to work. And people are looking into interference gamma signatures, the immune activated M2 as well, immunoproteasome as well. And of course, you also have cluster 3, which actually have TMB and coronary antigen and smoking signatures. And that's why what we're looking at is actually in future as well. And for those who actually are very keen into, I would say, in the basic sciences of things, which eventually will translate into clinical use, is looking into this kind of integrative study. And not only one factors, but multiple factors can be used and to be combined, and hopefully we can get a better or more perfect kind of predictive markers against these immunotherapy. So next is the way forward should be actually a multimodal integrations, integrating clinical, radiological, pathological, genomic, as well as transcriptomic. So you actually need the integration of every, I would say, discipline. All are very important. And this come from, I mean, the newer technology like multiplex immunofluorescence. You can, at this current moments, spatial transcriptomic as well. I think this is something that very robust. I mean, across the world, many, teams are actually looking into this. A lot of data is coming up as well. And of course, looking into single cell sequencing, not only NGS for the whole tumor, but actually a single cell so that you can have a more granularity of the results of the sequencing. And of course, blood-based biomarkers, the liquid biopsy and all those things that has been actually in clinical use at this current point in time. So that is the predictive biomarkers. And for the predictive biomarkers, I think essentially is there are so many things that we still don't know and so many things that we need to learn, and hopefully we can get a better predictive markers. Hopefully that predictive biomarkers can be used to predict actually which patients is or which tumor types is useful for certain type of immunotherapy so that we don't expose the patient to an ineffective drugs with side effects. So that's why now I'm going to go through the adverse events or the side effects of immunotherapy. This is completely new compared to chemotherapy. A completely different side effects as well compared to chemotherapy that we know, our good old friends, which we still use a lot. Yeah, especially in combination with immunotherapy or by itself. So, I mean, in logically, the side effects of immunotherapy depends on the mechanism of these drugs. The mechanism of this drug is using to enhance the immunity, our immune system against the cancer cells. So the side effects is over enhancement of the immunity against not only the cancer cells, but against our normal tissues. It's like we are creating actually an autoimmune disease in the body. So it means that every single organs in our body can be adversely affected by this immunotherapy, meaning everything is actually inflammation because immune system causes inflammation. So you can see from here, the adverse event can be across all the organs. And we see it as well from day to day. And we have actually a lot of clinical trials ongoing in our center, utilizing different type of immunotherapy and different combinations. So nowadays, actually, because we are doing a lot of immunotherapy trials, and at the same time as well, we are actually, using even a standard of care of immunotherapy as well. We see actually almost across all the organs what actually is happening, and from the adverse event of these drugs. Like for recently and currently, we are managing a panuveitis for the eye from our immunotherapy regimen, and also we are actually having few cases of myocarditis as well from these drugs. So what are the mechanisms? You can see from here, it's extremely complex as well. At different organs, the mechanism of immunotherapy inducing these immune-related side effects is different. So for example, one of the things that this immunotherapy inducing is through increasing the T cell activity against the antigens that are present normally in the healthy cells. Like for example, this is a reactivity against the normal antigens that the immunotherapy is working against. So for example, for myocarditis, this is the postulated mechanism. And another way is immunotherapy also increase the level of pre-existing autoantibodies. Like for example, for the thyroids, which is very common. We actually have a lot of patients develop thyroiditis from our immunotherapy that eventually all these patients will go into hypothyroidism, because when the thyroiditis, resolve, the whole organs probably, of the thyroid is not working very well anymore after the inflammations. So we need to actually give the hormone replacement lifelong for those, the patient that are affected by immunotherapy-induced thyroiditis. So it's actually through the mechanism increasing the level of pre-existing autoantibodies. And other than that, actually, other way of actually, the mechanism that be induced by this immunotherapy include the increasing level of inflammatory cytokines, which we know that actually immunotherapy can increase the inflammatory cytokines. And this is actually postulated to be affecting the colitis that happen in immunotherapy. And of course, even, our pituitary itself, the hypophysitis, there is inflammation of the pituitary, can be affected by this immunotherapy as the side effects of this immunotherapy by the enhancement of the complement-mediated inflammation due to the direct binding of the anti-CTLA-4 antibodies with the CTLA-4 expressed on the normal tissue. Because you have to remember that actually all these CTLA-4 PD-1 are also normally present in the normal tissues, but it's actually overexpressed in the tumor cells, so that the tumor cells can actually manipulate and dampen the activities as part of the immune checkpoint. And you may ask, if let's say there is so much side effects, so many problems with actually immunotherapy, whether it's good enough to be used or not. Of course, good enough to be used is already been approved. So definitely people look into the side effects as well. If we, let's say, compare to chemotherapy, the side effects actually is better, even though there are side effects. The frequency of the side effects is less, and at the same time as well, the severity of the side effects, for example, the worst side effects you can have is death. So the fatal immune-related side effects is actually less than chemotherapy. The death induced by chemotherapy. And from this both of these, chart. And that's why I would say that, immunotherapy is still some drugs that is well tolerated. We just need to know that potentially there is actually, side effects that can induce by it, and it's not difficult to manage as well, the side effects. So what are the patterns of RAE? What we need to know is actually when would this immune-related adverse event or immune-related side effects occur after you start the drugs. So the onset is served about 5 to 12 weeks after initiation. Yeah, then you start to see. That is a median. But however, it can happen within days of the first dose, and it can happen after months after the treatment, or even after you discontinue the therapy for various reasons. For example, unless the drug is not working anymore, you stop the drugs, but the side effect may still occur. The thing is that because immunotherapy itself, the half-life is very, very long. It's a very interesting, actually, compound, I would have to say, because it's not the drugs that we use day to day. Your half-life is like few hours or 1 or 2 days. This half-life can be actually months because of how these drugs is being metabolized. and this drug is being metabolized eventually, it's by the radicular endothelial system, not by your kidney or by your liver, like many other drugs. That's why it's very interesting, and that's also give us how come the drugs can be actually having still side effects after you stop it, because the half-life is very long. Another reason is sometimes because our immune system has has woken up, in terms of being induced by these the drugs, and eventually it start to continue to have activity despite you stop the drugs, because it's not a direct drugs against target effects. It's actually to enhance the immune system. Is let's say our immune system being enhanced, the immune system enhancement can continue on in terms of the effects. That's why nowadays we still don't know the exact durations. The best duration, that the most ideal duration, I would say, how long should we give it? Let's say the patient is responding. At this current point in time, a lot of time, the clinical trials as well as how we practice is up to 2 years. If let's say up to 2 years, the drug is still working, the patient is still getting benefit, we may stop. Because we think that, we postulate that actually likely the activity can be maintained because the immune system has been actually induced by these drugs and continue to work by itself. And of course, looking at this RAE as well, is a severity. And we know that actually different group, and we know that usually, let's say it's ADCT-OF4, is actually usually have high incidence, and the severity of the adverse AE usually is higher as well compared to anti-PD-1. Because like I've mentioned before, immunotherapy is so big, the area, the sphere itself, and there are different type of immunotherapy. So different type of immunotherapy, the severity of getting the, immune-related side effects is also differ. And you can see from this as well, the kinetics of the immune-related adverse events. And if let's say you ipilimumab, which is actually anti-CTLA-4, or you use the anti-PD-1 or anti-PD-L1, and if let's say you do the combination itself, you can see the kinetics actually, varies. And usually, in different type of organs as well, like colitis and liver toxicity, the endocrinopathy, the skin, and also the nephritis and pneumonitis, it happen usually the median time onset is differ as well from different organs. And if let's say you use combination, or you can see from here, the more drugs you combine, the potential, side effects or incident of the side effects and severity of side effects usually increase. So this is actually, what I want to actually show, are not infrequent, and when immune checkpoint blockade is used in combination. You can see 7.7% if let's say use nivolumab alone, and there's anti-PD-1 inhibitors. If let's say you use CTLA-4 by itself, then it actually increases what I've mentioned before. Anti-CTLA-4 actually a high incidence of immune-related adverse events. But if let's say you use combination, the adverse event can go up to about 40%. And how are we going to manage this? And of course, there are different guidelines, many guidelines that has been well established. It's not something very new, it's actually something very old. Yeah, more than probably 5 to 10 years already with this kind of guidelines being developed. But all these guidelines are not based on randomized control trial. It's very difficult to actually, have randomized control trial to just look at the management of this RAE. So these are actually, from all the data being collected from real world studies, as well as, of course, from randomized control trial for other things, but not specifically the randomized control built for this management of RAE. So generally, we grade our immune-related adverse events into different grades. So grade 1 is usually asymptomatic mild symptoms. And in those kind of situations, we may just do observation, we may give some supportive care and continue on with our therapy. But if, let's say, go into grade 2, grade 3, or even higher grade, then we may need to start, our immune suppressive therapy, because you know that a lot of this is actually the overactivity of the immune system. So we throw in actually like corticosteroids to actually dampen the overactivity. Hopefully we can reverse the RAE itself. So at the same time as well, we may actually have to, sometimes like grade 3 or grade 4, we have no choice. We have to stop the drugs. We cannot use the drug anymore. Because if, let's say you re-challenge back, let's say it's very high, it's very severe side effects, the side effects may recur again and patient can die from it. And you don't even have patient to treat thereafter. Yeah, I think these are the guidelines for steroid therapy. I mentioned it quickly. And usually we'll start high dose steroids, let's say, especially for grade 3 and above. Adverse events from immunotherapy. And subsequently, we will taper it off. And usually we taper it off over a month or even sometimes 4 to 6 weeks. We don't taper it off very rapidly because we may see actually rebound or recurrence of flare of the whole thing if let's say we taper it off too fast. And of course, we need to actually manage the side effects of the drugs that we give to dampen this, like for example, corticosteroids as well. Because we know that corticosteroids, they are long-term use or even a medium-term use, there are a lot of side effects that may actually cause issue. Yeah, like for example, hyperglycemia, at the same time, adrenal insufficiency, and also muscle weakness, all those things we need to take into account as well. And the way to actually, let's say we use, like for example, steroids high dose for long term, we definitely will add in actually Bactrim to avoid the possible problem of actually like, I would say, the pneumocystic coronary infections. And other than that, you can see from here, the most IRAE are usually reversible with immunosuppression of steroids. Yeah, you can see from here, after we use the IRAE, then you can see, like for example, GI endocrine hepatitis, the pneumonitis or nephritis, usually they resolve, yeah, with your high dose steroids. But one thing that's very interesting is actually the endocrinopathy, meaning let's say you have thyroiditis, adenitis, and all those things. Then the issue is after the organs, the endocrine organs have this information from the immune-related side effects. The issue is the function of the organ itself. You may lose the function permanently, but this is not something very difficult to manage. We just need to actually replace back the hormones. So, the approaches, how to actually, look into how to manage it is actually multidisciplinary, because the thing is that when we treat the cancer, any organs with immunotherapy, any organs can be adversely affected by this immunotherapy. And so we may need help from gastroenterology, let's say it's colitis, dermatitis, then we ask help from actually dermatologists as well. And one important thing is to monitor the patient when patient is on it, and then try to prevent it as well. Inform the patients, inform the healthcare providers, look into the risk that the patient may develop, especially unless the patient already is an autoimmune disease patient, then there is actually a higher chance. And we may not start actually immunotherapy in those patients actually have very, very active in autoimmune disease still ongoing. Yeah. And try to prevent this kind of thing from happening, and you anticipate it as well, that this thing may happen, and closely monitor it. And if let's say you anticipate it, you're going to detect it early. And unless you detect it, then quickly treat it with, immunosuppressant. Because if let's say the patient is very, you don't detect it early, patient, when go into these adverse events and develop very severe one, they may die from it actually. If let's say you detect it early, you treat it early, and patient, all these unnecessary death, actually the fatalities can actually be avoided. Yeah. And this is about the side effects of immunotherapy. I would like to move next is looking into the future. What are we actually looking at? I think this is very important. I specifically actually bring this up because I think we have a lot of basic sciences people here as well. I think a very important field area that is very fast developing and we're looking into it actually is the microbiomes. We know that the bacteria itself is so important that it can affect the activity of immunotherapy. And the picture on the left is the very famous hallmark of cancer, which every 10 years people add in a new hallmark, meaning a new mechanism that why cancer happened and what actually drives the cancer. So the latest thing actually happened in 2022. This hallmark cancer, you can just Google it and look into it and then read about the paper. The hallmark cancer is a very interesting paper. It's quite a lengthy paper, but it actually tells you everything about why cancer is formed and what is the mechanism. And almost every 10 years, there are a new version of this hallmark of cancer being developed. So in 2022, one of the important area actually that we know that is going to cause, or induce or drive cancer actually, or also affects, negatively our drugs, is actually the microbiomes. It has been included in the latest hallmark of cancer, which 10 years ago, people, don't even include this in the hallmark of cancer. There is less hallmark of cancer in terms of the, cause cancer. And you can see from here, different type of bacteria, the beneficial part, the harmful bacteria, and different factors as well. Like for example, the antibiotic use has been actually associated. Let's say a patient have a lot of antibiotic use, you can actually change the flora of our guts, and all these things may actually affect the activity of our immunotherapy. And at the same time also, you know, a different kind of, I mean, mechanism like epithelial barrier fitness in our guts. I mean, all those can actually affect as well the health status of the patients, and all those can actually affect the, I mean, the activity of our drugs. And the whole microbiome itself is a very exciting space. And hopefully one of our friends currently in the meeting can actually embark on this, or if let's say you're doing it, please do it more, because they can tell you there's a lot of promising things happening here. And at the same time, what is next for microbiome as well? It's a very difficult space to actually navigate. It's just because a lot of things can affect microbiomes. Like for example, the food we eat, the unrefined carbohydrate and sugar itself can actually change our microbiomes. Of course, we know that healthier food like as vegetable, legumes, as well whole grains, all those things are good for our guts bacteria. And of course, yogurts, like other fermented food, like dairies, the yogurts, all those things are good as well for our microbiomes. And of course, high quality proteins. But antibiotics and microbiomes is fairly well established. Antibiotics may change microbiome, and usually it's a negative impact against our microbiomes. And there is actually, I mean, way of treatment that we can actually transplant our fecal material from one patient to another patient's. Yeah, and hopefully we can change our microbiome through this, what we call fecal transplant, fecal material transplant. It sounds a bit not clean, but actually it can be actually being used and at the same time being developed so that it is actually the very clean version of how we do the fecal transplant. And this can actually restore, actually, I mean, our immunotherapy activity. So I think the space is super exciting. Yeah. And another area I would say that's even more complex, I think, is the tumor microenvironment. I just learned that Unimas actually now currently actually an expert in this area. I would love to actually work with all of you. Let's say you are in this area, please. I mean, we can I mean work with, I mean collaborate. Yeah. And so you can see from here in 2013, publication itself, we can see the how mechanism of the carcinogenesis, what is happening in the cancer. In 2023, 10 years later on, people start to factor in tumor microenvironments. You can see the picture itself, I mean the graph itself, the picture itself, there is actually additional part. There is a tumor microenvironment. And what we know as well at this current point in time, the tumor microenvironment in short itself is some of the tumor type is actually immune deserts, meaning there's not much of immune cell you can see one. And this kind of cells, this kind of prognosis of this kind of cancer usually is not good. And you can actually, I mean, have those very, very inflamed tumor. And you can see a lot of cells, you know, white cells is actually in that tumor microenvironment itself. And those kind of tumor, usually we say that they usually respond better, but it's not that easy, it's not that simple. There is more than that. Yeah. So I would say that, you know, there is immune desert, immune excluded, and also immune inflamed. Currently, what we know about tumor microenvironment. And what is next? The tumor microenvironment. You can see from here, there's a lot of factors that influence the tumor microenvironment. It's so busy. I don't think you can read the slides itself. But I mean, and there's so many things, not only the cells, not only other factors, the cytokines and all those things are very important as well. These challenges is always opportunity, what we always say. So you can see that it's very challenging because there's so many things that influence the tumor microenvironment. They also give you ample of opportunity to actually develop strategy against it. So, and what another thing that made things even more complicated is this tumor microenvironment is not static, it's dynamic. The changes of cell in this tumor environment, all those things is actually very dynamic and keep on changing. And at the same time also, tumor microenvironment can differ from one organs to another. So meaning different tumor type in the same patient or even the metastatic setting itself. I mean, if let's the patient have metastasis in one organ to another organs, the tumor microenvironment may not be the same also. So meaning it means that you have a lot of complexity and actually challenges to actually develop drugs against it. Eventually, whatever we want and whatever we do in basic sciences, I think what we hope for actually is translation in clinical use, translation actually into, I mean, benefits that can benefit patient. So that is why, I mean, collaboration between clinicians as well as basic scientists is extremely important. And you have a lot of systemic influence as well that can actually, I mean, influence tumor microenvironment, like microbiomes, the metabolism, the diets, the exercise, the underlying condition, the comorbidities of the patients, and the obesity, like drugs and all those things can actually cause the changes in this area. So like just like I mentioned, you can see from here, these are also an opportunity area to improve, and things are moving very, very fast. And you can see as well, drug has been actually developed against this tumor microenvironment. Some very successful, some actually fail. Yeah, and fail miserably as well. So, and you can see from this chart itself, I mean, there are barriers for this tumor microenvironment against the drug that we use, and there's also opportunity that we're looking at, and a lot of robust development have been done, and different categories also of drugs or the therapeutics area that we can do. And you can see from there, I mean, on your right. So these are very interesting thing that, I mean, in the future, what I'm looking at, these are only a few examples that, I mean, due to limitation of times, you know, we're talking about this, the tumor micro and the microbiomes that I think I have no choice, but I had to put it in because I think these are very important areas, and hopefully we can actually work together in this area as well. So at the end of the day, I promised you before that the last few slides, I'll tell you why is driving a car. I think now you probably understand why is driving a car. So immuno-oncology, again, analogically, you make it very simple. It's just like driving a car. Why we say that it's driving a car, you can see from here. So when you drive a car, you actually need to start the engines. Engine actually the priming of the immune system. Like the priming itself can be a therapeutic opportunity. Like for example, the cancer vaccine, all those things, and adult T cell therapy as well, turning the tumor into a vaccines. All these things are actually priming, and this is actually starting a car. And at the same time, just like I mentioned, the two big category of immune agonists and immune checkpoint, the immune inhibitions. So it's actually a homeostasis. If let's say a normal person in homeostasis, there's always a homeostasis between the immune agonist and immune checkpoint. But I mean, the tumor itself is so smart, trying to be very smart and try to outsmart our immune system. They manipulate this immune agonist and checkpoint part of our immune system, try to dampen the immunity so that our immune system can't recognize them, or even if you recognize them, have no power or progress actually to, hit the cancer cell itself. And so these two parts have a lot of molecules that I have mentioned before, and all these molecules are potential targets for actually the drugs development. And of course, not forgetting our tumor microenvironment. There is actually the highway. You need a highway to drive your car. You can't drive your car in the jungle unless there is actually no roads. So this is actually why I put up the highway itself. So there is a lot of things in the highway as well. The tumor microenvironment part, you can see the microbiomes, the tumor microenvironment itself, different molecules in that tumor microenvironment, different cells in the tumor microenvironment, different cytokines in the tumor microenvironment, all play a role. Yeah, in terms of how these drugs going to work, whether they're going to work itself, let's say they're going to work, why it stopped working, and all these are actually all the questions that we still need to answer. And eventually, I think this is my summary slides. This is my last slide. And lastly, I really have to thank you all for your attention, for spending time with us and discussing this, cancer and immuno-oncology. Thank you.
Thank you so much to Prof. Voon for a very interesting and very enlightening lecture, very knowledge fact, I would say. Do you have any questions, those who are on the Zoom there? Perhaps I will start. Actually, I have quite a few questions.
Yes.
Number one is for what are the costs of starting the immunotherapy, and does it cover by our GL for those who are to
It's a very good question. It's very realistic as well as practical as well. I mean, at this current moment, the only drugs that recently been approved by our Blue Book, I think all of you probably know Blue Book, meaning our formulary, meaning if they can get it free, from the government service, is actually only in atezolizumab in hepatocellular carcinoma. Even though you can see that, that's why I show you the slides that there's so many drugs have been approved.
Yeah.
In Malaysia, all these drugs have been approved as well. It's just not reimbursed. Approved is not equal to reimbursement.
Okay.
Yeah. In terms of GL, I think it depends on actually your department as well. Whether because it's extremely costly for these drugs. Like for example, one of the drugs actually costs about 17,000. This is after some of the assistance program from the company, like every 3 weeks. And you may need to use up to 2 years.
So the 17,000 is for what you mean for how long? You mean for each?
Oh, one cycle.
One cycle.
Every 3 weeks you do pay 17,000.
Every 3 weeks. Every 3 weeks, 17,000.
Yeah.
And usually those who start on chemotherapy, I mean immunotherapy, you start for at least 2 years, is it? Yeah, what you say?
Let's say it's
maybe
working well, we don't stop it earlier
Mm.
because not working well, or
Mhm.
we stop usually for two reasons. Number one is, let's say the drug is not working well, or there are too much of side effects that we cannot actually continue on. Then we usually will stop probably about 2 years time, which actually the duration itself is still something that people are debating it. Yeah. But most time at this current moment, all the clinical trials and the thing moving forward is probably 2 years. So 2 years, you can calculate, let's say 17,000, 2 years, and it's just for the drug. So it's not actually, it's just purely for the drug cost. Around 17,000, not even we said it mark up from let's say from a private hospital, all those things. So it's extremely expensive. But one of the things that I mean, Sarawak patients sometimes we so-called is a bit luckier, I would say, because we actually have a lot of clinical trials, and a lot of patients actually get immunotherapy through clinical trials. Yeah, we have actually, and this I always said that, you know, I'm actually actively involving in clinical trials. And one thing is that I mean clinical trials is something that I mean at this current point in time, these are the future drugs. In drug development, I mean, one drugs when they go into clinical trial, especially when they go into first in human, it takes about 5 to 10 years before it's being marketed. Yeah. And being approved by the regulators. And the regulator I mentioned here is actually FDA, not Malaysia regulators. FDA. Yeah, if let's say FDA approve it, then it can start to be used in US, and EMA is Europe. Then eventually you come to the Malaysian shore, probably 6 months to 1 year after that. Yeah. And when you come to Malaysian shore, I mean, we still can't afford it. Because when it's approved, it means that they sell it commercially. So that's why I mean all these things is that our patient actually have a chance to actually be using the future drugs. That is why I mean nowadays many patients willing to actually participate in clinical trial as well. Yeah, yeah. And any question from you all? Any over there? There's a question from Woon Ling. Said hi, Dr. Woon. My friend, 70 years old male, had metastatic lung cancer, 4 tumors detected in December 2023, and then 4 more popped up in the early 2024, underwent cyberknife robotic radio surgery, and his sole treatment, and now all the tumors are gone. May I know if this kind of robotic surgery in SGH, and if this is apart from immunotherapy for this local patient? No, this is not immunotherapy. This is what we call local ablative therapy. Yeah, actually, it's not as simple as what you call it cyberknife robotic radiosurgery. And actually, there's more options than this. And there are different kind of way of doing it as well. So different way of kind of doing it, like for example, there is actually radiofrequency you can use, ablation wire through, I mean, you burn it. You can use cryotherapy as well. You can actually use even microwave, or actually, I mean, different kind of things that we can do. And I have to say that, you know, I can't comment much actually on, like, you know, four tumor, then it disappear. Yeah. It doesn't mean that actually, you know, it's going to work for everybody as well. I think it's good that your friends, the thing is working for him. Yeah, I think that is good. But we can't comment much. It's just because they probably have some systemic treatment the patient is still undergoing. Yeah, that actually may help out as well in preventing this, or whether this is because the tumor kinetic itself, I mean, the tumor biology is so slow that after 6 months, 1 year, it's still not growing back. Yeah, that's why, I mean, sometimes some tumor is super aggressive. Whatever you throw into the patients, it may not work at all. Meaning you can use immunotherapy, the latest thing in immunotherapy, the thing may not work at all. Yeah, you can radio frequency it, you know, radio surgery it, multiple one, but it keep on popping up. But some is like, you know, you leave it there for a few months, the thing is just not growing, despite you don't do anything. Sometimes we can do even monitor, I mean, sometimes you can see that we give drug holiday for patients, because we know that, I mean, a lot of time from the time that we have actually time point to look at the kinetics of the tumors, then we know that probably this tumor grow very slowly, then we may not actually need to actually, I mean, be so aggressive in terms of treatment. So there are so many factors. Yeah, but I'm very happy that your friends actually have, I mean, good effects from this way to doing it. And of course, I mean, local ablative therapy is things that, especially what we call oligometastatic lesions. Oligometastatic, I mean, these are all oligometastatic. I mean, meaning there's not many tumor metastatic sites. not many cancer sites in that one person, and local ablative therapy may be useful. It is not applicable for everybody. Let's say there are multiple sites, you can't burn everything. Yeah. So one thing is that then you burn, then subsequently you see in 1 month time everything come up back again. Then you cannot keep on burning, and a lot of time we may need to use systemic therapy. That's why it's very complex. But of course, we are very happy that your friends actually is benefiting from this cyber-knife robotic radiosurgery. Actually, yes, is available in actually, I mean, in Sarawak General Hospital. And my colleagues team from RESPI actually recently started one very important trial as well, looking into, I mean, ablative therapy. I mean, try to burn the tumor via bronchoscopy. But it's not like, you know, it can help a lot of patients. There are criteria to it. It's not everybody can use it or relevant to everybody, because sometimes all this is not come without side effects. And whether it's going to be effective or not at the end of the day.
Okay. The next two questions are from Aziza. Number one is there any general or standard criteria for patients suitable to receive immunotherapy? And if I add on to these questions, is it like you mentioned about those with acute autoimmune is one of like some sort of contraindication, right? Is there any like some kind of which type of acute inflammation is not severe enough that you can still start? Maybe that's the question number one. Maybe you answer that question first.
Is there any general, I would say, standard criteria for patients suitable to receive? We actually, just now, that's what I mentioned before. I mean, regarding the predictive biomarkers, there are some actually established biomarkers that we can use to predict whether the drug is going to work or not. One of it is actually PD-L1, which is actually fairly established. If let's say your PD-L1 is high, then the chances for the drugs to work actually is there. Okay, high. It's not 100% as well. So just now I have mentioned repeatedly as well, it's not some zero game. It's not 1 or 0 kind of thing. It's actually a spectrum, 0% to 100%. So the higher it is, it doesn't mean that actually the drug definitely is going to work. So sometimes we don't actually have, like, you know, can tell you that, oh, this patient, if let's say, I mean, you use the immunotherapy, definitely going to work. It's not. We may can tell you that there's higher chance for it to work or higher chance for it. These drugs may not work. I think, but of course, when we use the drugs, it have to be follow the indication being approved. It's not like we can just use the drugs, whatever we like. And all this indication is, the approval indication is by our regulators. Like Malaysia is MPRA, like US is FDA. The actual indication is, let's say, it's within the indication of usage. Then, because the indication where it come about, the indication come about is from the studies. I mean, from the evidence that been generated through clinical trial, through science. It's not like, you know, people just can say that I want to use it, I use it. I have money, I want to use it. No. If let's say the indication is not there, because the thing is that if let's say use it outside indication, you actually may be doing harm to patient. The drugs may not work, and then because in the study itself, certain type of cancer may not be effective. So you may actually just giving, I mean, side effects. I think that is very important. And for your question, Prof, regarding the, I mean, acute inflammation, and we actually will give a case by case basis. Like, for example, I think we put it in the perspective is like, that's I do in autoimmune disease, the patient with autoimmune disease, whether can we actually give or not? If let's say it's still very active, the autoimmune disease, patients still require high dose steroids, having complications, autoimmune disease, the disease is very active, usually we know. We may use alternative way of treating, but if let's say autoimmune disease well controlled, now on very low dose of steroids, usually we say it's 10 milligram and prednisolone or below, or without even steroid usage, and this we may actually use it. We can do, but of course the caveat itself is we are going to actually monitor closely, making sure that actually the patient won't redevelop or having a autoimmune, I mean, flare from our drugs. And actually, I mean, she has another question on giving cancer patient prebiotics or probiotics as a supplement. I think this is something that a lot of people are doing. I don't think we have a very strong evidence in this as well. But of course, I believe that, I mean, you eat well, all your food, and at the same time as well, I mean, don't abuse antibiotics and all those things. Then you probably, I mean, you know, also producing as equal effectiveness of the thing that you hit doing probiotics and all those things. and making sure that, I mean, this would actually influence our microbiomes.
I think not even just for cancer patients, even for normal healthy people. Now people take a lot of prebiotic and probiotic. You know, I think what the evidence behind all these things is actually quite.
I can't comment. I'm not expert in this area, but of course can tell you that there's a lot of things that we can do besides that. It's like for example, you just eat well. Just now the legumes and vegetables and all those things, and high fibers thing and all those things, and at the same time also don't abuse drugs.
I'm not sure if I miss out part in your lecture earlier. How long do we give a trial to see how the patient will respond to the immunotherapy and not actually?
Usually, I mean, this is based on the principle of oncology that cancer care that we are doing. Like for example, I mean, if let's say when we treat advanced stage cancer, every 3 to 4 months we're going to repeat a CT scan, or we repeat some imaging to see whether the drug is going to work or not. The reason why we do so, people may ask, how come I keep on receiving CT scan? Because one thing is that, unfortunately, the science today cannot predict us or tell us there's no perfect drugs that 100% they're going to respond. And how long they're going to respond, it's not forever as well. In advanced stage, I have to be very specific. Not early stage. Early stage is different, totally kind of different story. So in stage 4 disease, these are things that's why usually the way we do it is about 3 months. I mean, a scan, a 4 cycle, a scan. Because if let's say you're doing clinical trials, you may actually do it every 2 cycle, because they want to capture the data as well to see when is the progression-free survival is the data itself. But for reality in our setting, we can't be like asking patient to go for scan. Patient may not want to do it. And at the same time, also our radiology department not be able to cope as well. Let's say they keep on, I mean, we have so many cancer cases nowadays. That's why I think these are the important thing that, I mean, that we need to know. And we usually 3 to 4 months.
So practically in our setting is also 3 to 4 months. Okay.
But the way that we do it is we may space it out. Let's say this is very well controlled. We think that there's not much of issue, If let's say there are a lot of side effects from the drugs, we may actually do it even more frequently. Whether this drug is still working or not, or whether at the expense of the side effects of the patient.
We have another question over there in the room. So Voon, is there any clinical trial for relapse cancer, thyroid cancer?
Unfortunately, at this current moment, we don't have thyroid cancer. I mean, trials at this moment. In the future, potentially, yes. We are in the midst of discussion, but it may take a few months to bring this trial in. We are trying our very best actually to bring as many trials in as possible. But I mean, it's not easy to bring trial in. Every center in the world are trying to actually fight for trials into the center. Everybody want actually the latest drugs to be used. Unfortunate, but I mean, we from time to time we look into, I mean, different kind of cancer. There will be more trial coming in, definitely. We'll be getting more and more trials coming in for patients in Sarawak. Thyroid cancer is something that actually we are looking at, and we're actually in the midst of discussion on one of the thyroid cancer trials. It's still in the early stage of discussion. We are foreseeing it probably end of this year, probably we may have it.
So that's our last 2 questions. If there's no more, do you foresee in the future that immunotherapy will overtake chemotherapy as the mainstay of treatment, or the cost will actually come down in the near future?
I mean, there are 2 questions in your question.
Okay, all right. Okay.
So the first question itself is actually, if let's say you ask me whether it's going to overtake chemotherapy, I think probably is in combination. Nowadays, we use a lot of combination. Synergistic effect. Additive or synergistic. It may be additive, may not be synergistic. Or hopefully we want synergistic, meaning you double the, I mean, the effectiveness or even more than that, with the combination. So I think we cannot replace chemotherapy. But one thing is that, I mean, it may be used for combination. If let's say we have a better predictive biomarkers, we may be actually just use actually monotherapy. This is something that we are looking at actively, actually looking at it. And additional to that, I mean, the second question is
the cost.
Come down or not? I would say that, it's a very complex question. The older generation, I mean, older here, it means that, like, for example, like 10 years being approved is already called old here, because the things just move so fast. The new things just keep on coming out. So for the older one, there's a lot of biosimilar coming up. the biosimilar coming out, biosimilar probably I just give a very, simple explanation here. In drugs, when it's been developed and eventually get approval from regulators, the drug itself is called innovative products, and they have patency. So the patent itself, carry probably sometimes 20 years.
20 years.
And at that time, only one company can produce it and to protect the patency. And of course, other company can't do it because legally they can't do it. Yeah. And however, you have to know that, in drug development, a lot of money have been actually invested by that company for their R&D. And so, they have the rights to do use that patency for 20 years. At that time, the drug cost is usually very high. Nearly the end of the patency period, you see that actually a lot of company, especially some of the biotech company, will come out and they do biosimilar. And biosimilar is different from generic. Generic is actually for new chemical entities. Like for example, like our usual drugs, like antihypertensive drug, all those things, easy to actually produce generic because they just need to prove that these two drugs are actually equivalent in terms of the chemical and do some, simple study. We call it BEBS study. Yeah. But for immunotherapy, all these monoclonal antibodies, the issue is very different because all these are protein. Protein varies. The batches of protein, even the same batch from the innovative product may vary slightly. So actually the regulators require them to run the trials again.
Okay.
Yeah, and the trial is to compare with the current immunotherapy that has been approved. And that there is a biosimilar of the thing. Of the drugs. So that will take about a few years to actually being completed. So you can see that when the Pembro is going to expire in the next few years. So you can see that a lot of biosimilar trials coming out. At this current moment, we are doing quite a few as well. So that's why when it come out, then you have a reduction of the cost of that drugs. But the reduction of cost, is it going to be very cheap? Not really as well.
More complicated compared to
more complicated
production.
because you need to pour in the investment into the R&D for the biosimilar. And the other thing is that when you produce the drugs in the factory, it's actually producing protein, it's antibody. So the cost of the production is actually fairly high as well. So you may see a bit like 30% or 40%. It is offhand. I can tell you it's not like what I say is true because it all depends on the dynamic of the market as well. And how many competitors in the markets and all those things. So, and how good is technology at this moment in the future as well. The technology usually brings down the cost. So it may be you can see that a reduction of pricing for about probably 30 or 40%. So it's still going to be expensive despite that. But one thing is that on the other end, it's going to be even more costly because we are doing combination now. Our drug development, we are doing even more newer generation. Then a lot of generation of drugs is doing combination of immunotherapy, meaning IO, immuno-oncology, immunology drugs. So if let's say you have two drugs together, one drug already cost you this kind of money, you have two drugs, there'll be a lot of issue. That's why it's something that affects globally in oncology. And actually, unfortunately, this is the reality of life that we hope that equity of access for cancer care. And unfortunately, reality of life is usually those advanced countries with advanced economy, they get a better care than country that is developing or underdeveloped world because it's just too expensive for us. And hopefully, I hope that in the future that we have a chance to actually reduce it and actually improve the equity of access for all patients.
Yeah, actually another question you might can answer this. If you have been on immunotherapy for a while, will you develop the antibody to the drug? I think you talk about that resistance.
It's not that straightforward. It's not just developing antibody against it. It's actually a lot of mechanism behind it can happen. That after you use it for a while, some patients actually have a long-term benefits, meaning after a long time, patients still actually respond to it. Still being controlled with it. We have this kind of patient as well. But
it still can respond
even we stop the immunotherapy. We have patients like that. But many patients as well may not be actually benefiting it for a long time. Even you spend so much money and all those things on it. It may work for a long time, but of course the science said that this is the standard of care at this current point in time. Saying that this is supposed to be the way we treat it. For those not working, there are many reasons. and we are not able to fully understand all the reasons still. Yeah, it's an area for research actually.
Tumor
Meaning,
microenvironment.
yeah, tumor microenvironment, things change in the tumor microenvironment. The tumor itself can actually use alternative pathway to actually drive the cancer, which actually bypass the pathway that you are trying to drug against. And at the same time also, I mean, extrinsic factors like the way that, I mean, you know, the microbiomes even can actually reduce the effectiveness of drugs. That's why what we can say that overall is mechanism of resistance definitely is present when the drug is not working anymore. But what is the mechanism of resistance? A lot of time we can't tell you because it's not because we don't want to tell you, it's just because we don't know. Because it's very molecular, we are not able to actually know
what's
as well.
happening down
Down
black
there.
box.
Okay.
So like, you know, just a related question. For those like, you know, develop the IRAEs, quick three, grade 4 one, then you have to no choice but to discontinue it. Do you see a rebound on the tumor progression, like it certain accelerate?
No. Actually, there are some data suggesting that it's suggesting only, it's not 100% as well. Nothing is 100% medicine, unfortunately. It's just because the science haven't reached there. It's not because we don't know or we can't tell you. Yeah, I mean, the development of human and all those things, our science is not there yet. Yeah. And one thing is that, I mean, a lot of time we associate that, you know, if let's say patient develop a severe IRAE, the immune-related side effects, actually the drug is a bit more effective. And a lot of time,
it can be more
after you
effective.
develop this kind of very severe side effects, there may be a continual control of the drugs. I mean, control of the tumor, even the drug is not continue anymore. Yeah, so that's why it's very interesting, the whole area itself. Immunotherapy is totally different from what we always learn about our drugs, because immunotherapy is not directly killing the cancer cell. It's actually, I mean, utilizing our immune system. So if let's say we start to wake up, then they may do the job themselves. You just need to have a kick on them, and after that, they start to do the job themselves. So patient may not need to continue on the drugs. That's why nowadays we don't even know the ideal actually duration of the best duration for immunotherapy. But we always set at 2 years for multiple reasons, for the side effects as well, for the cost also. We can continue on if let's say, you know, the drug cost is like 10 to 20,000 a month. Yeah, that's why I think that is I think it's very important.
But for a last question, for the patient or family members out there in the room there, what are your important points about patient education that you want to highlight?
I think importantly here, I would say that, you know, immunotherapy is actually something not very new and something not very old as well. But of course, it's going to be effective in different type of cancer, but not all the cancer. It's not for everybody as well. And at this current moment, there are so many unanswered questions for immunotherapy. The science try to answer it. Who actually benefits more? From this immunotherapy, specific immunotherapy, and there's a lot of development as well. So the hope is there. That I mean, there is more things coming in. Definitely, we know that as well because we are doing a lot of clinical trials. And this clinical trial, we see that very, very powerful drugs is coming in. But of course, these are not approved drug yet. But they actually, hopefully, it's a future promising drugs. And in terms of, let's say you are currently using it, then of course, I mean, watch out for the immune-related side effects. And you do not need to know everything about it, but let's say you're not well, all those things, please let us know and let the treating physician know. And we need to investigate whether it's actually, I mean, immune-related or not. It's not an easy thing, very complex as well in terms of diagnosis. We are getting more used to it because we're using it more and more. And at the same time, it's something that is manageable. So I think I can say that let's say you're using it, I think, and it's working well for you, I think you're very lucky. And I would say that, you know, continue with it and at the same time also live well. I think that's super important. You can see that microbiome itself actually is very important. I mean, live well, always people will ask what type of food can I eat? I would say that just a well-balanced diet. Don't do extreme thing.
I think the very issue is a cost prohibitive or inhibitive. This amazing.
They want. I can't comment much because to be honest, this is another area of its own, the pharmacoeconomics. They're expert in this area as well. So they can calculate whether the cost is actually effective or not. And there's so much thing inside it. It's not evidence-based, but very best medicine. In that area, they're expert in this area by itself. And how to look at the cost. And they look at cost not for individual patient. They're looking at cost for policy making.
True,
That is
true.
actually looking
That's why we need
taking
more
care of
data.
the forest,
Mm.
not taking care of the one tree.
True.
Yeah, that's why there's a lot of thing, and pharmacoeconomics is something that is very robust as well.
Yeah, true.
And you have to see whether at the end of the day, when you use these drugs,
Mm.
whether this drug actually have any economics. I mean, is
Translate
actually
to
translate into
money and
benefits,
cents or not.
yeah, to all the patient or not.
Mm.
Yeah, that's why I think that
Policy
is
making.
very important for policy making.
Okay. Right. Any other questions from floor here? Is it due to efflux pumps, genetic mutation, and all those things?
No, there is actually, I mean, it can due to many various factors. Yeah, that's what I mentioned before. Yeah, it cannot be just due to if can be due to efflux pump possible as well, but may not be as well. Yeah, because you have to understand. Yeah, these drugs is a monoclonal antibody, especially what we are talking about the antibodies. Antibody don't go into the cells, so there's no chance for this antibody to be efflux out.
Oh yeah.
Yeah,
True.
yeah. But of course, after the antibody being bind to the receptor, there may be a cellular, I mean, activity that's happening, and all the after, I mean, the products, all these activities, maybe it flux out. That's possible.
That's true.
But the drug itself cannot be
It cannot
actually
be,
flux out
not,
because it's
the
not able to
mechanism
go
of
into the
action,
cells itself.
different.
So, but of course, I mean, genetic mutation, although it's possible, acquired resistance a lot of times is from the genetic, I mean, newly acquired genetic mutation. Actually, this kind of thing is very interesting. There's a lot of theory behind it. It's just I mean, Darwinian theory as well. You know, it's a pressure selection as well. When you give a drugs, you pressure it, and then some other type of genetic mutation just come out.
Oh yeah.
Yeah, you pressure it, and that's why. I mean, and that's why it's very interesting. So yeah, archival sample, that is a thing that how important it is. Let's say you are the basic sciences, let's discuss further. I think it's a biobank that we need. We don't have, I mean, a very well established biobank at this moment. But let's say you have any activity, you have any good ideas, all those things we can always discuss. And there is always, I mean, archival issue that is available, or we can even do biopsy.
Yeah.
Okay.
Yeah. Thank you so much to Prof. Voon for very interesting talk, and as he has highlight, I think there are many areas of collaboration in terms of research as well, right from basic sciences to from the social aspect of it, as the pharmacoeconomy as well. And so Prof. Voon is one of our adjuncts, so make full use of his expertise, you know, for course supervision in terms of your PhD and MSc students, as well as your own personal grants, research, and everything. There's so much things that we can talk about for cancer, right from clinical to, you know, that's why I asked I don't know why my MSc and PhD students are not here. You know, they are working in the lab, but they are doing cancer-related studies. You know, they should be here so that we can have more interactions as well.
Yeah. Prof. I think probably one thing is that I think for everybody online, or I mean, presence as well, that I mean, we are trying to actually build our cancer care, to improve our cancer care.
Yeah,
there's so much gap in our cancer care in our state. I mean, our home, I would say, Sarawak is our home. So one thing is that I really hope that, you know, we can actually work together in this area. There are a lot of opportunity, many things is untapped. A lot of, like, you know, the research opportunity out there. We just need, and then every single area, not only that drug development, not only basic sciences, like for example, even psychology, you know, oncopsychology, all those things, that if let's say you are in now today, and hopefully you want to do this kind of thing, then we can always, you know, you let's say you have a PhD project, all those things, we have one, I mean, I think currently doing with us as well. I mean, in our, I mean, is working in our department doing this, and cancer survivorship and all those things. Every single discipline. Yeah. Because there is a whole, we are very receptive.
Yeah.
We welcome you to work with us, from our oncology department, and hopefully we can actually improve the care of the people here.
Yeah. All right. I think that's all for today. Prof. is very approachable. I'm sure you can. You will prefer email or just a WhatsApp message. Email. Those who want to, you can email to him. Maybe you can type your email here so that they know that they can. The last one. Then yeah.
How to go to? Yeah.
Okay, so I have put down there Prof. Voon's email address. So those who would like to contact him for further collaboration, and so I know can make an appointment to talk in person in oncology clinic in SGH lah. All right. So I think that's all. Again, once again, thank you very much to Prof. Voon, and thank you for attendance. Though for those who are attending it online, although I wish to see more attendance in the physical space here. All right, I think that's all for today. Thank you very much.